Hey guys, can you see me and hear me? Just give me a yes or a no if you can see me and hear me. And if you guys are live, I'm doing it without some support for the first time. So I hope I'm audible and visible. Yes, no, maybe. Can you guys hear me, see me? I hope this time the stream will not be interrupted and we will be able to learn in a better way possible. Right? Thank you. Thanks a lot, Mirabai. Okay, so guys, welcome back to the RxDX Pathology channel. I'm Dr. Anjit if you're first time here. So what I thought is like we will do a everyday Telegram session, but Telegram doesn't seem working. That's why like I'm thinking of going on the YouTube, and if you miss it, it'll be on the YouTube as well for some time, right? So I told that I'll be discussing about the recent advancements of the hematology or histopathology, which comes as a tiny booklet, which is one of the papers in your university exam. This is from the latest histopathology one, 26th edition. One of the first topic is about the pathobiology and the morphology and clinical significance of thyroid, minimally invasive thyroid neoplasms, right? See, first of all, there's one important thing which I want you to remember. This actually is not a recent advancement. The 20 the WHO fifth edition of endocrine has already incorporated all these changes. So when the book came, it is definitely a recent advancement. As of now, it is actually not a recent advancement. So I think this will help us a lot in saying that we have already learned this. So if something comes in terms of recent advancements of pathobiology of thyroid neoplasms, it is the WHO fifth edition, which is the latest one. Apart from that, there's no advancement in case of thyroid neoplasm, right? That's what I want to first talk about. So now what happens is I'm going to talk about primarily three diseases in this category, which all of them there has been subtle changes from the previous way what we perceived about invasion in case of follicular thyroid carcinomas, NIFTP, and also we there is one new category called as an undetermined malignant potential, which is initially not there, right? So everyone, welcome guys. I want a little bit of an active participation more. So if you can hear me and see me, say hi. Let be more enthusiastic. Let's learn pathology with a little bit more of love and affection so that we don't feel it as a burden, right? So first thing, we will be going to follicular carcinomas. What are the changes in follicular carcinomas and what you have to look into a slide when you get a slide? And I obviously have a look at the slides as well, which is says from WHO or from our archives. Okay, so these are the three things by which great Praneeth, a great start. These are the three things under which hello Jasdeep. These are three things under which we report follicular carcinoma these days. We call them a minimally invasive follicular thyroid carcinoma. Please remember, this does not mean it is less invasion. It's not like that, right? Hi, Francis. So minimally invasive follicular thyroid carcinoma means I'm having only capsular invasion. That's what I mean by minimally invasive. Doesn't mean that, okay, this is a complete invasion, this is a minimal invasion. Not like that. The term minimally invasive is used when you have a follicular carcinoma with only a capsular invasion. That's when we call it minimally invasive. Please don't mistake that. That's one of the important things you have to know about it, right? Then we have something called an encapsulated angioinvasive. Previously, it was the old WHO was only angioinvasive. Then we had a distinction of less than 4 and more than 4. Though the less than 4 more than 4 is there for prognostic impact, but I have only angioinvasive. Encapsulated. It does not matter what is the status of the capsule here. It should be encapsulated. Capsular invasion may be there, may not be there. Doesn't matter for me if it enters the vessel. What do you guys think? Good or bad? Just the Praneeth, Mirabai, Francis. What do you think if it's entering into the vessel? It's obviously resistant, bad prognostic factor. The job of the pathologist is not just to report, it's just to prognosticate, right? Capsule means there's a tumor, it has gone here, so maybe it can go to the local invasion, right? Local nodes. Yes, I can go to the local nodes, local tissue. Yes, possible, right? Amazing. When it goes into the vessel, it has access to the entire body. That's why angio invasion is always bad, because it gets access in the entire body, can go to the brain, can go to the spine, anywhere. So obviously it gives a very bad prognostic sign. And when they say widely invasive, this is, I need not struggle. I can directly say, yes, it's an invasive thyroid cancer. Maybe I can see them even grossly. It's extending outside the capsule and going to the adjacent structure. Or when you do a microscope, I know for a fact, okay, I have multiple nodules here, very well demarcated, widely invasive follicular carcinoma thyroid. Under FTC, FTC is the abbreviation. We have MIFTC, which is minimally invasive, encapsulated angioinvasive and widely invasive follicular thyroid carcinoma, right? Clear with this? Any doubt? Shoot it right away so that we'll get it sorted here and there, and then let's go to the next one, right? Now the question is, how do I diagnose capsular invasion in case of a thyroid biopsy or a thyroid resection specimen, right? You must have seen this. How many of you have seen this image before? Because I feel that this is one of the commonest Google image, especially when you have follicular adenoma. You want to confirm whether the capsular invasion there or not, right? So most of us Google capsular invasion. Obviously, you look at this image. This is the first hit which comes on Google. This is an outdated image, right? Here, you will not have a problem with this. No one has a problem with this. No one has a problem with this, right? Whatever has been yes marked here, no, they are very easy and straightforward. But none of the cases comes like this. What it says is like all the widely invasive cases, which is rare, is what presents as this C, F, and H, clear-cut invasion. That is never the confusion because it's anyone can say it. The first year resident entering can say yes, it's invaded and gone outside. Where I'll have a confusion is, if you guys can agree, let me know. This one and this one is what confuses a lot. How do I differentiate I, which is not yet invaded, and yes, D, which is invaded? Actually, we'll come to this also soon later half of the lecture. No is different, not yet is different, and yes is different, right? Obviously, the confusion becomes between D and I. I'll tell you a simple rule. This is there in the new WHO as well. To identify capsular invasion, the first thing it is said that is we have to look at the capsular structure or an architecture, right? You have to draw an imaginary capsule. Let's say you have a microscopic image. You have to draw a imaginary capsular outline. This is the capsular outline I'm going to ask you to draw. This is imaginary, right? I'll show you in a case that will be much easier and definitely easier for us to go and have a look at it. Can you see the slide? If so, tell me a yes. I hope you can see it, right? So this is the capsular outline. Like just a second. You can see the capsule, right? You can definitely see the capsule here all around. This is what I'm saying. Draw an imaginary capsular outline. That's very, very important for you to draw an imaginary capsular outline. I'll tell you why this is important and how it can make my life very, 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 very easy and simple. Now, let's go back to this. Now, let's say I'm having a tumor which is going into the capsule like this. Can I call this invasion? Yes, no, maybe? Come on, guys, let's be active. It's fine if you're wrong. I'm never going to do anything or scold you. I'm not your professor. I'm not your reporting staff. Yes or no? Can I call this? Absolutely, I can call this a capsular invasion, right? Now I'll ask you one more simple question again. Okay, I want more guys to answer the same Praneeth just with great effort, right? I want more guys to interact with us. So perfect. Now the problem is whenever a tumor invades the capsule, can I say it can produce a desmoplastic response? Yes, it will definitely produce a desmoplastic response. Yes, any tumor which invades will have a desmoplastic response. That is the concern for me and that is the primary problem for me. Because desmoplasia is nothing but fibrous tissue, right? Non-neoplastic fibrous tissue is termed as desmoplasia. What is capsule? Fibrous tissue. So what happens is this kind of will merge with the capsule. Now then I have a problem again. Is it looking inside the capsule or it's gone outside the capsule? That's where my capsular outline will help. Let's assume that I am not able to differentiate desmoplasia and the capsular invasion. Removing the tumor, I'm just removing the tumor, imaginarily removing a tumor. The outline of this will become like this. Yes? Do you think this projection is normal, abnormal? Is this capsular outline normal, abnormal? It's abnormal. A capsule cannot poke in ways where I want. Capsule is defined, right? It should be defined. A capsule will never poke. A capsule will not be like this. A capsule will be perfect. That's what a capsule is. Do you guys agree? So now, how capsular outline will help me is, if it is like this, then I can say there is no invasion. On the other hand, if my capsular outline is like this, I can say there's a projection going inside that's going outside. Or I can say, if it's like this, I can say, okay, some guy is going here. Okay, some guy is going here. That's why it's causing excess desmoplastic response and merging with the capsule. This is what WHO clearly says, that draw a capsular outline that makes your life much easier. Let's go to the case what we saw. Look at this. I hope you can see this case. Look at this. This is from WHO, from the blue book. A normal thyroid, little bit of maybe a lymphocytic thyroiditis here. Now I'm just going to draw a capsule, a capsular outline, a capsular outline, a capsular outline. Fine with me, fine with me. Tell me, what is the right root of this capsule? This here, the first one, or this here? Which you think is a normal outline? I cannot draw on this slide. Tell me which is the normal outline. The one here is a normal outline, or the bump is a normal outline? I want you guys to comment. Keep this as first one, keep the thing as second one. Which is normal? One, perfect. The first is the normal outline, which means this also looks like capsule only, right? This is not capsule. This is a tumor's desmoplastic response. The normal capsular outline here is, let's zoom out. I'm sure you can see the normal capsular outline. So whatever has come on the top is actually the desmoplastic response capsular outline. So I don't call this as, why I'm telling you is, don't get confused with this. This is not the thing. This is not what we see there. That's not what we saw there, right? What I'm seeing here is actually a tumor which is going ahead. Okay. There's actually a tumor going into it. It's not seen within the capsule. This is my original capsule. It's gone outside the capsule and has created a desmoplastic response which is merging with the capsule. Clear? Perfect. At the same time, let's go and have a look again. Again, look at this. Capsule, capsule, outline, 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 outline. Now tell me, what should have been the normal outline? Merge here or go and take a bump like this? Again, I'll give an example. Merging here is A and going a bump up is B. Which is the normal capsular outline here? Merging or going up? Obviously merging, right? So now this mushrooming is by default invasion. This mushrooming is by default invasion because it's outside my normal capsular outline. This is by default invasion because it's outside my normal capsular outline, right? Perfect. So you should never have a doubt with capsular outline going forward, right? Now, if I take this, okay, this is capsular outline. This is capsular outline. I don't have much of change here. Let's zoom in here. This is not changing with the capsular outline. This is a normal capsular outline. I won't call this an invasion. This is within my capsular outline, has not gone inside. This might be in the circle what we saw. This part will correlate with this. It's within the capsule. It's not an invasion. Rest everything has dented the capsule or protruded the capsule. That is when I call it a capsular invasion. Is that clear? I call it an invasion of a capsule when it produces a dent and alters the course of a normal capsular outline. So next question is, when do I actually look for invasion? There are few soft signs. This might not be in your books. If you look at books regarding frozen section, or if you practice a little bit more, you will definitely come to a point that when you have a thick capsule, please always look for capsular outline. There's a clue. There's a very soft clue. Same image. Same image. Let's say it's not. This capsule is definitely thick, right? I cannot have a capsule this thick. It's huge. Think of a capsular invasion by default, right? A thick capsule is always a clue to search for invasion. Or give multiple deeper sections. Has to be done. Never ever forget that. That's one. Second one, when you have a capsule which is incomplete. An incomplete capsule, always again search for invasion or take deeper cuts. I'll tell you what do I mean by an incomplete capsule. Incomplete capsule is something like this. I got only till this. This part is not there. That's what I call an incomplete capsule. Why this is important is, maybe when I go to deeper cuts, I might have a protruding tongue here. Or I might have tiny deposits here, right? So make sure an incomplete capsule and a thick capsule always search for deeper cuts and invasion, right? Perfect. I hope you will never have a doubt with follicular thyroid carcinoma capsular invasion. When it invades capsule without angio invasion, I call it an minimally invasive follicular thyroid carcinoma as per WHO 5th edition. It's not just follicular carcinoma, we put it as minimally invasive if there is no angio invasion. Clear? Done? If done, give it a thumbs up. Let's go to the second one, which is encapsulated angioinvasive. Fine. Perfect. Pathology is good. Pathology is easy if you know what to look for. The problem is it's very vast. You're not knowing what to look for. That's the issue, right? Let's go to encapsulated angioinvasion. For this, I need to know what does angioinvasion mean. That becomes a bit of a difficult task. The first and the foremost rule of angioinvasion, the vessels I'm going to look for should be either within the capsule or beyond the capsule. Within also is accepted. Don't always search for vessels outside the capsule. It should be within or outside. It's okay with me. But it should not be inside the capsule. That's very, very important. What do I mean is, let's say this is our capsule here. Okay. I'll zoom this a little bit. I have a vessel here looking like invaded. I'm okay. I will take that. I have a vessel here searching for follicular thyroid neoplastic cell. I'm okay with it. But if I have a vessel here, even though if it has an embolus, this is not to be considered. This is something which most of the students make a mistake. They always search for a embolus inside the tumor, because that is how we did for breast cancer, right? When you report a breast cancer, you look for lymphovascular emboli, not always outside. Even if this is inside the tumor extent, you say it's embolus present. But that is not true for angioinvasion in case of a thyroid neoplasm. Clear? That's the first rule. The vessel should always be either within or outside the capsule. It should never be inside or within the tumor substance. That's the first rule. Then, when do I call it angioinvasion? There are three rules to call angioinvasion. The first rule, let's say it should be attached to the vessel wall. When it's attached to the vessel wall, by default, I can call it angioinvasion. It's not rocket science, right? I have a blood vessel here. Let's assume pink for tumor cells. I have tumor cells attached to the vessel wall. It has to be firmly attached to the vessel wall. Then you know, okay, it's an invading tumor. I don't have a problem there, right? That's one. Okay. Second is, if the tumor emboli is surrounded by fibrin. I'm sure you must have seen fibrin, a pink color proteinaceous deposit. The concept is very simple here. This is a vessel. Let's assume angioinvasion means tumor from here is going to invade. That is angioinvasion. If a tumor cell actually invades, it will destroy the vessel and enter, which means it will have fibrin around it. That's all. Okay. So if you have a tumor cell, a vessel here, let's assume this is my tumor here. In the center it is there and it is surrounded by fibrin. I don't have another pink color, so I'm drawing a green color, right? This is fibrin. If it is surrounded by a fibrin, even though it's not attached, still I am okay to call it an angioinvasion. The third rule is, if the tumor is surrounded by endothelial cells. This might become a little bit tricky for us to call. If required for this, use immunohistochemistry. Use a simple marker. If your college has ERG, that's the best marker to identify endothelium, or D240 or any endothelium marker you have, you can use that. Sometimes if you carefully observe in 40x, you can easily see that as well, right? 3 times I can call for angioinvasion, attached to the vessel, surrounded by fibrin, surrounded by flat endothelial cells, right? Now, I am going to show you an image, which is this from WHO. I want you to have a look. I am going to mark few areas. I want you to tell what they are. If you're wrong, it doesn't matter. There are 17 of you online. I want every one of you to comment on that. Please do comment. Let's break our inhibition. Let's talk here. Let's make our mistakes here. Let's make no mistakes in the exam. This is a vessel with a tumor. The T here is tumor. This is the outline of the vessel. Can anyone tell me what are these cells? What are these cells in the wall of the vessel? I hope it's visible. If you want, I'll zoom it a little bit. The tumor is the T and the vessel space you can see. Perfect, Francis. That's your, do you accept it, Francis? As your endothelial cell. Amazing. This is my lumen. This is your lumen. That's endothelial cell. Let's go here. You can see a couple of tiny RBCs here. So I'm sure it's a vessel. That's my first thing. I have to make sure it's a vessel. The next thing is, this is a tumor. I'm going to just look at the corners of the tumor. Can anyone tell me what is this cell? Maybe I'll use a red color arrow mark. Tell me what are the cells which I'm marking with a red color arrow mark. The red color arrows, red color arrows. What are these? What are these? Look at this. Look at the beauty here. What are these? What are those? Those are also endothelial cells. Can I say now this fits into my third criteria for angioinvasion? I am having tumor surrounded by, wrapped by, look at this. It's actually wrapped by endothelium, right? So if you have tumor cells wrapped by endothelium, I can definitely call it this criteria angioinvasion. If you require, do a marker. Doesn't matter, but it's not required generally because you can appreciate you are able to say it's an endothelial cell. That's enough. Be confident, go ahead. See more cases, you'll never have a doubt at all, right? That's when I call it encapsulated angioinvasive. Perfect capsule, no infiltration, only angioinvasion, encapsulated angioinvasive. This definitely carries a bad prognosis. WHO does not insist on calling how many vessels are involved, less than 4 or more than 4 like the previous time, but definitely is more than 4 vessels with angioinvasion. Obviously, the prognosis becomes worse, implying that there's more chance of spread. That's it. It's very simple. There's no rocket science behind it, right? So this is what is an FTC. Minimally invasive FTC, encapsulated angioinvasive FTC. Widely invasive, I'm not going to that because once you know capsular invasion, grossly you can easily pick it up, right? Now, the new WHO has this. This is the primary thing to differentiate between your FTC and where I'm not comfortable in calling it invasion, or I know there is no invasion. We have a new list of tumors called as low risk neoplasm. There's a very high possibility this itself can be asked as an essay in recent advancements. Talk about the low risk neoplasms in case of thyroid as per 5th edition of WHO. There are 3 tumors. I had put one video on HTT in the same channel. Have a look at it once you finish the session. Then I have non-invasive follicular thyroid neoplasm with papillary-like features. Most of you must have seen these cases or at least read once, right? At least once, right? More than once also you must have read, because NAFTP is something which will always be a confusion for us. You'll always look for what is NAFTP, how do I diagnose NAFTP? Very simple diagnosis. There are 7 points. If you have a note, write down the 7 points. We'll see a case with most of the points there, right? Then thyroid tumors of undetermined, uncertain malignant potential. Okay, UMP is uncertain malignant potential. This is something which is newly introduced and we have subcategories of this. We also will see if the time permits, right? But NIFTP is definitely something which you're going to see for sure. Okay, I'll go with NIFTP first, then I'll come to this. Okay, NIFTP is non-invasive follicular thyroid neoplasm with papillary-like features. Okay, one thing is very, very clear. This tumor should not have invasion. No capsular invasion, not even doubtful. No invasion at all. That's the first thing, right? There are actually 7 points here. Okay, we'll look at all the 7 points. First, it should be encapsulated 100%. There should be no invasion or even no doubt of invasion. I don't even have a doubt of invasion. That is first thing. That's the first thing. Non-invasive, first point, right? Non-invasive NIFTP, follicular thyroid neoplasm. That's my second point. If you know the abbreviation, we can know most of the points here. I should have follicular growth pattern. That is important. I should have follicles or a follicular growth pattern. That's a second finding. And papillae should be less than 1%. If they are there, there should be no psammoma bodies. If you see a single psammoma, I'm not going to consider as an NIFTP. No psammoma bodies, papillae less than 1%. 2 important criteria. Third, again let's go to the name. NIFTP, non-invasive follicular thyroid neoplasm with papillary-like features. That's the third thing. I should have nuclear features of papillary thyroid tumors. Fine. The nuclear features should be of papillary thyroid carcinoma. In this, I have a very important thing. There should be a score. The score should be 2 to 3. Can anyone help me with, since we are not discussing much, I want you guys to comment on whatever comes to your mind when you think about nuclear features of PTC. What all comes to your mind? When you think about nuclear features of PTC, anything which comes to your mind, let me know. I'm sure there are a few things which will definitely come to your mind. The nuclear feature of papillary thyroid carcinoma. Come on, at least one guy you will say. The big guy. Orphan Annie is something which you'll never forget, right? Right? It's okay. If you're wrong, it's completely fine. Comment. Crowding, overlapping, nuclear enlargement. Perfect, Francis. Anyone else? Clearing. Super, right? So there are actually 3 points for me to call the nuclear features of the papillary thyroid carcinoma. Grooving, intranuclear inclusions, nuclear grooving, amazing, right? The 3 points. One is with respect to my nuclear size and shape. Okay. The first thing with respect to nuclear size and shape. Under this, most of you guys what you said, nuclear enlargement, elongation, overlapping, crowding, everything comes here. Okay. Your enlargement, okay, overlapping, okay, crowding, everything comes here. That's with regards with size and the shape of the tumor. Next comes your nuclear membrane irregularities. In the nuclear membrane irregularities, what does come? Irregular nuclear membrane, which is nothing but grooving, pseudo inclusions. Under this, I'll have grooving and pseudo inclusions. This is very important to know and very important to remember also. I'll tell you why. Third is where your nuclear clearing comes, or Fanani. Okay. So now, like I said, I need to have 2 on 3. These are the 3 points. If you see in a NIFTP suspected case, only grooving, only inclusion, it's not 2 points, it's only 1 point. Only nuclear membrane abnormality. That doesn't fit. I should have crowding overlapping or crowding plus grooving plus clearing. So if you have, these are the 3 points, if I have at least score 2 or 3, then only I can call it papillary carcinoma like PTC like features. Is that clear? Any doubt, do let me know. These are the 3 things I consider: size, shape, nuclear membrane irregularities, and the nuclear chromatin clearing. I should have in this 2 or 3. Minimum 2 is required. If it's only 1, it does not qualify or quantify into PTC, right? That's a third rule, right? So it should be encapsulated, NAFTP, obviously it should be encapsulated. It should be follicular, again NAFTP, papillary, again NAFTP, right? Okay. The fourth one will actually be included along with this only. Encapsulated, clear demarcation with no capsular, no vascular invasion. I should have no vascular invasion also. Not just capsular, vessel invasion also should not be there. 5, there should be no tumor necrosis. Like I said in the start, this is a low risk neoplasm. I should have no tumor necrosis, no features of high grade. I should have very low mitotic count, okay, which is equal to your less than 3 per 2 millimeter square high power field, okay, less than 3. That's the low mitotic count. And the most important thing is I should not have any other features of papillary thyroid carcinoma like a follicular variant, okay. Other than follicular variant, I should not have like tall cell, cribriform, no other. Follicular variant is allowed, right? Other than that, they should lack the rest of PTC's variants. If I have in a corner tall cell variant or a cribriform variant or a solid or a trabecular variant, I will not put them under NAFTP. It's a PTC with features like this, fine? Is that clear? These are the 7 pointers. Encapsulated, no invasion of capsule, no invasion of vessel, low mitotic count, no necrosis, no papillae, follicular pattern only, no other pattern allowed, and the most important thing is nuclear features of PTC of minimum 2 to 3, right? Let's go to a slide. Let's see if we can diagnose it, okay? It's not a very easy one to diagnose. Let's see. Can we accept that this is a very well encapsulated lesion? Not much evidence of invasion? Yes, no, maybe. You can actually see a very clear demarcation, right? Will you accept? First criteria sorted? Yes, no, maybe. I want you guys to comment. If you are writing it down, keep the 7 points with you. Let's see. Okay, perfect. Next, will you also accept that I am having follicular pattern? of thyroid neoplasm? Not difficult to identify. See, when I say follicular pattern, remember macro follicle, micro follicle, fetal like follicle, everything goes to follicular pattern only. I do have good big follicles, I do have small follicles also, right? So second point is also done. Do I have any papillary network anywhere or some of my bodies anywhere? See, because the patterns can be appreciated only on a low power microscopy, nuclear features can be appreciated only on a high power microscopy, right? Perfect. I don't have anything. It's predominantly follicular area, no papillae, no some of my bodies. So that also sorted. If you want, let's go and have a look at the findings. So in this, as of now, what is sorted is this is sorted, this is sorted, this is sorted. Uh, this I don't know. We'll have to see if we go to a little bit in high power microscopy, but I don't think so. There's a very good necrosis here, right? Now, what is important for me is it actually papillary thyroid features or is just a follicular a tumor? It could be a simple follicular adenoma, right? I need to have the papillary thyroid like features. If it's not there, then I will not be able to diagnose it. Let's go deep dive into it. To identify PTCs, till you get superb experience, go to minimum of 20x. Don't try to do it in low power because we get used to told my seniors that go to low power and diagnostics, right? Sometimes low power might not help, especially when I'm going to look for the nuclear features. Okay, let's see if we can find some nuclear features. Okay, look at this area. I hope it's zoomed and it's visible, right? Do you accept there is crowding and overlapping? Yes, no, maybe. If you feel it's not there, you can say clearly it's not there. In the center, I hope I can show it with my hand. In the center, do you feel this area is crowding and overlapping? Yes, no, or maybe. It definitely has crowding, right? That's definitely has crowding. It definitely is overlapping, which means one of the three scores is sorted, right? The first score was size and shape. Definitely has crowding and overlapping. By default, I do have a little bit of nuclear enlargement as well, right? I am not sure if you can see this. Let's see if I can focus this. What do you see in this nuclei? See, it's not a microscope, it's a digital slice, so you have to little bit get adapted to it. What you're seeing in this nucleus, I cannot zoom beyond that. What you're seeing in this nucleus, that is a groove. Are you convinced that is a groove? Perfect. So I have 2 of 3. Actually, can you see a groove here as well? You can. The beauty of grooving is you start seeing one, it look like many other cells are having a grooving. Actually, this is enough for me. I have 2 of the 3 features of the PTC, right? Perfect. Now, let's go a little bit here. Though not a clear orphan Annie, is there nuclear clearing? It's not a perfect orphan Annie. I'll definitely accept. It's not like a PTC. I have a clearing here. I have a clearing here. There's a nucleus. It's completely clear, right? Look at this nuclei. I have a little bit of clearing here. I have a little bit of clearing here. It has clearing by default. Look at this. Will you say that's clearing? It's definitely clearing, right? Will you accept this as a clearing of nuclei, nuclear chromatid? Definitely you will, right? So which means this biopsy has by default crowding. Do you accept? We saw grooving, that's a nuclear membrane irregularity, and we do have clearing, though not classical of a PTC, but it does have clearing, right? So which means this also is sorted. My nuclear features is easily 2 on 3 if I can push 3 on 3, but score 2 is enough for me to call it a nuclear PTC like findings, right? Perfect. So that's how you identify NAFTP. I hope you'll never have a doubt again with NAFTP. If you're confident, put a thumbs up again. Let's go forward to the next lesion, right? There are 3 tumors which comes under the pathobiology of new changes with respect to thyroid cancers. One is FTC, one is NAFTP, then next is UMP, that is undetermined or uncertain malignant potential. Fine, great, perfect. Now let's go to this. After we're done with this, let's move to the final thing. Okay, so thyroid tumors of uncertain malignant potential. What has happened is, I'll just go to the first follicular invasion here. This was the image which all of us were used to, right? The concern here is, I gave the new WHO very clear statement of what is invasion. I also gave the new WHO very clear statement of what is not an invasion. But I didn't give a clear statement of what is not yet. Previously also I didn't have a clear statement of what if it's not extending outside the outline but it's still inside, like what we saw in this slide, right? Like what we saw here, it's not going outside completely but looks like it, right? So what do we qualify, what do we quantify there, right? So what we go for that is, that's where your UMP comes. Thyroid tumors of uncertain malignant potential. This is the extract from WHO exactly. Are well differentiated thyroid tumors with follicular architecture that are encapsulated or uncapsulated but circumscribed with invasion which remains questionable even after complete sampling. So what do you mean by questionable invasion? Questionable invasion, the criteria is also very questionable. Like I said, in the image, when something fits into not yet, I call it a questionable invasion, right? In this, I have two types of UMPs. One we call it an FTUMP, which is follicular tumor of uncertain malignant potential. Other one is WDTUMP, which is it's a well differentiated tumor of uncertain malignant potential, right? These are two UMPs what we have, well differentiated and a follicular type. Okay, clear? So what do we call it a follicular type of uncertain malignant potential is, you have tumor cells that are regular, that lack nuclear features of PTC, but I have a questionable invasion. I call it FTP because it is follicular tumor. You have a nuclear feature of follicular tumors or follicular neoplasms. Okay, PTC features should be score 0 or 1. It should not touch 2 PTC nuclear features, and I have a questionable invasion. So questionable invasion, like we saw in the image, this is an image from WHO again. We had a superb capsular outline here. We had a capsular outline like this. This is how it was. Okay. This was the thickness of the capsule. This was the thickness of the capsule. Okay. And I had a tumor which went inside this. But it's not altering the thickness of the capsule, but it's still making my capsule thin. This is what I call it questionable invasion, right? There is no alteration in the outline, but it has gone into the capsule with certainty. I'll show you this image. I hope this image is clear and it's bright. Is the image bright? Okay. If I call this my capsule, okay. If I call, the outline might be kind of like this. This is the thickness here. Here the thickness is little bit, maybe I should have drawn a little bit that side. Yes, somewhere like this, right? But if you look at this, the outline is not altered, but this guy has gone here. This guy has gone here. It has made the capsule very thin here. Do you accept that? If yes, comment yes. Yes, definitely. In the sides, I have this much thickness, but the center, it's become smaller because the tumor is pushing. It has not caused a desmoplastic reaction. If it had had a desmoplastic reaction, I'd have altered the outline of the capsule. So it's questionable. It's no desmoplastic reaction. Outline is maintained, but still it's trying to push. Rather than invasion, it's pushing inside. Maybe in after a few years, it might invade. Who knows? So this is what I call it an questionable capsular invasion, right? If you have like this, I call it FTUP, UMP. It's a follicular tumor of uncertain malignant potential, right? The next one was, just give me a second. The next one was a DMPP, is well differentiated tumor of uncertain malignant potential. Here, I'll have nuclear features of PTC, not follicular tumor. It's a well differentiated tumor, right? WTMPP is here, nuclear features will be of PTC 2 to 3. Okay, score of 2 to 3. When I say 2 to 3, it's a score of 2 to 3. But again, questionable invasion. Okay, I am not able to find the invasion in spite of thorough sampling. If invasion is excluded, then it's different. But I'll have a questionable invasion. Same questionable invasion looks like what we saw previously. Okay, clear? Fine. Now we have got four different tumors: follicular carcinoma of thyroid, NAFTP, right? You have a FTUMP, follicular tumor uncertain malignant potential, WDTUMP, well differentiated tumor uncertain malignant potential. So the concern is, how do I actually come to a conclusion? If you have WHO, please get new WHOs, at least not now when you start reporting. WHO is an amazing source for us to report. The boxes are the gold mines of WHO. There's a box of WHO. I'll tell you how to fill the box, but I want you guys to help me with everything, fine? So here on one side, I have PTC type nuclear alterations, which means if it's 2 to 3, I call it present. If it's 0 to 1, I call it absent. In between, I don't know what it is, right? Here I have invasion. Again, I have three parameters here. Perfect invasion is what we saw in MIFTC, minimally invasive follicular thyroid cancer, the alteration of capsular outline. No invasion is nothing, completely normal. Questionable invasion is what we saw now. It didn't push outside, but it made the capsule very, very thin. Clear? So with these parameters, I'm going to write where does it form, where does it fall, right? We'll start with some easy things. I have nuclear features of PTC, but there is no capsular invasion. Who will come here? I have a nuclear feature of PTC, but I do not have a capsular invasion. Who will come here? I'll give you options. Options makes us our life very easy, right? Will it be follicular thyroid carcinoma? No, invasion will be present. Will it be UMPs? No, because UMP will have questionable invasion. Will it be like what Francis said? NAFTP? Perfect. I'll have NAFTP. Amazing. That's what I'll have here. Non-invasive follicular thyroid carcinoma with papillary-like features. Clear? Now let's go to the next one. I have absent features of follicular thyroid tumor. Okay. I want more people to answer now. Listen carefully. There's no nuclear features of follicular thyroid, papillary thyroid carcinoma, and I have a questionable invasion. Can anyone tell me who will come here? A clue: everything in questionable invasion, only your UMPs come. Who will come in this category? No nuclear features of PTC and a questionable invasion. Great, Mirabai. Here it will be an FTUMP, follicular tumor of uncertain malignant potential, right? Now I know, hope you got what is the gist. Let's fill the rest of it also, right? I have a questionable PTC, which means score of 2 approximately, and definitely a present PTC. In both of this, who will come? Will it be FT or UDT? Just that alone. Who will be there here? It's questionable invasion, but nuclear features like of a PTC, which is both of this here. Will be well differentiated tumor, uncertain malignant potential, well differentiated tumor, uncertain malignant potential. Fine, perfect, right? Let's complete it. It's not difficult. Stay with me. Many of you guys are there. I want everyone to comment. We know this. We know this for a fact, right? Now let's say I have an absent nuclear feature of PTC, and I have a capsular invasion present. Who will come here? It's very simple here. Who will come here? Everyone, I want you guys to comment. It's easy. I have an invasion present. Invasion present, only one diagnosis. And there's no nuclear features of PTC, which makes our life much easy. Perfect. That is follicular thyroid carcinoma. That's all, right? If invasion is present, it has to be FTC, follicular thyroid carcinoma. It can be nothing else, or a follicular carcinoma of thyroid, whatever it is, right? Okay, minimally invasive. Mirabai, it's minimally invasive, not micro-invasive. Fine. Minimally invasive, FTC is the right answer. Fine. Okay. Now let's try to fill up this as well. When it's questionable PTC, this also goes to NAFTP only. Okay. Now tell me what will be here. I have no nuclear features of PTC. Okay. But there is no capsular invasion also. Tell me who will come here. By the way, all this will have same follicular pattern. All this will be in follicular pattern tumors only, not in papillary pattern tumors. Remember that. Follicular pattern tumor, no nuclear features of papillary carcinoma thyroid, no invasion. Who will come there? It's an easy guy and it's an easy guess. Amazing. I'll have follicular adenoma. Simple. Done. That's all. Right? Now, let's fill the other two guys as well. Why to leave them alone? Right? So, if it's a questionable PTC and a follicular pattern with invasion present, which is well differentiated carcinoma NOS. This also is a new one. I don't have anything to put into well differentiated carcinoma NOS, not otherwise specified, right? Okay. Next, what will be there if I have a nuclear feature of PTC with a follicular pattern with the invasion? Can anyone tell me what it will be? We have not discussed it today, but I'm sure you must have seen this patients and you must have reported this patients. What will be here? Nuclear features of PTC, follicular growth pattern, and invasion present. It's simple. I'll give you more clues if you require. It's a PTC with a follicular variant. That makes my life very, very easy, right? It's an FVPTC, follicular variant of papillary thyroid carcinoma. It's invasive, encapsulated. The terminology has changed, that's all. Follicular variant of papillary thyroid carcinoma, because all these starts with encapsulated follicular pattern, right? It's an invasive encapsulated variant of follicular variant of papillary thyroid carcinoma, right? I have added a lecture on this in the RSTs app. If you have access to it, please download the app and have a look into it, fine? Okay, that's it for today. So I hope you like the lecture. If you like it and if you want your friends to learn, please share the video. Let's try to be a little bit regular and hopefully we will ace pathology one by one. But I'm sure, see, I'm giving you a tiny schedule. I will do work for you. I will read the recent advancements. I'll create a PPT. I'll take class. A simple query from you. I want every one of you to at least minimum see 3 questions a day, 3 slides a day from the app, right? Hopefully you'll do that. That will cover close to 150, 200 cases in fingertips. You can ace any exam, fine? And morning, read 2 hours of Robbins, either from Robbins' book or from the app with the help of lectures, fine? See you guys. Thank you so much. Thank you for your amazing time. And we'll diagnose many, many things together. Bye-bye. If you have any doubts, do let me know. If not, let's call it a day. No issues, Pranit. We'll learn more things together. Learning should not be a barrier at all. Let's learn many more things together. Okay. Thank you, Pranit. Bye-bye.